Unfortunately, I've got a lot more slides than I planned because I had revised them down, so I'll go through them quite quickly. And, well, ENT's role in sleep apnea diagnosis, the definition of the condition is upper airway obstruction. The nose is the true first part of the respiratory tract. We do share the airway with the chest physicians. Mike's done all the numbers and presentation about definitions, mild, moderate, and severe. And I suppose you as a group are really quite interested in the mild and moderate group where mandibular advancement devices are very good. I'm very supportive. And I think that historically, the way things were set up is that sleep apnea was a domain of the chest physician. But now, chest medicine and ENT work really well. Certainly in allergy, we've been doing joint clinics for 15, 20 years. It's not a new thing. And actually when I started off with a chest physician who just happened to be the medical director, which was actually very helpful. He can clear all sorts of obstacles out of your way. So teamwork works well, and I think there's a huge role for MDTs, and certainly dentistry, maxillofacial surgery. You all have a role to play. This is a huge and exciting area to be in. It's more the serious side of medicine, but because it's the more serious side, you have to be a bit more careful. So aligning yourselves with a good clinical service, whether it's medical or surgical, is probably a good idea. Other features, loud snoring. We've all heard this, as Mike said. You know, it's funny if it's happening to somebody else. I've had various patients come to see me. If you don't sort him out, I'll kill him. There are different ones where they tell you that you can psychologically traumatize the dog. It sounds funny until you're in that relationship, you're sleeping next to that person, and your relationship is in tatters. You wake up tired in the morning, both of you didn't sleep well, and you go at it. If you're not in the same room in a relationship, that's a big step in your relationship, and sometimes it leads to divorce. Loss of interest in sex is always a very worrisome thing with men. If you're tired all the time, you tend to be depressed. In fact, I just anecdotal, I had a lady who works for me in my reception in my practice in Pilgrim, who's been treated for depression for 25 years. And she's been working with me for 7 until she kind of broke down and was off work. And then, you know, light bulb went on. So she's got sleep apnea. 48 hours later, she's absolutely fine after treating therapy, you know, after 25 years. So sometimes something's so close to your face, you don't actually see it. So do think about it. And the associated diseases, hypertension, obesity, well, obesity is going to be the biggest thing that we're worried about, and there seems to be a pan-European, if not global, phenomenon. Hypertension, strokes, diabetes. A lot of the patients that come into my clinic have already been to cardiology. They're already in the diabetic clinic, but trying to convince cardiology and other endocrinology to work with you. You see, medicine works in silos, either your ENT, respiratory, general medicine. But now we're getting a stroke physician in our service, and hopefully you'll give us some sensible medical advice. This is a lovely graphic which in a summary just outlines all the impact of hypoxia to every part of the body. There's no cell in the human body that doesn't need oxygen, just some are more sensitive to others. So you start thinking, well, stroke is pretty bad. Mood disturbance, that's very, very common. When you wake up grumpy, you're grumpy at work, you're tired all the time, you start picking arguments, your work productivity can drop by 30%. Over time, these people with severe sleep apnea, untreated, has about a 15% 12-year mortality, a 35% 12-year chance of having a major stroke or heart attack. So it's all serious stuff, and you don't want to just give a mad out to somebody and then have a legal issue later on down the line because you didn't actually work that patient up. You just gave them a therapy, and if you think about medicine, medicine is all about history, exam, investigations, then therapy. So if you're anxious or worried or concerned, work in partnership with a local service. This is one of the things that on the OSA working group, Epworth is dead. It's out of date now. You want to move towards the stop band questionnaire, which is developed by an American anesthesiologist. And it's quite easy. S, snoring, probably in a separate room as well. Could be heard in a different room. You're tired in the morning. You've got observed your partner's observed apneas. You got high blood pressure. That's what the P is for. Your BMI is above 35. your age is more than 50, your neck size is more than a 15.5, and your gender is male. So it's a quick, easy one for you guys to administer. If you're thinking about it, stop, bang, very easy to do. It's far more targeted. Epworth is actually a measure of sleepiness. It's not and it's very soft and woolly, but unfortunately, historically, it's always been used. So a lot of the papers quote on Epworth now, but as the working group recommend, we should move towards stop, bang, so that will come through in the next year or two in the literature. Standard sleep study. Mike's covered most of these things. It is an interesting field for you to get into, and the home diagnostics can be very, very elegant. This is a WatchPat, which is a tier 3 study, so it looks at sleep architecture as well as all your respiratory parameters. But you know, the buying price of these start at about 5,000, so it's not, you know, an occasional hobby. You've got to be doing enough of these to justify it for you. And this is what Mike was talking about. I don't know at what point these should overlap. But certainly, if most of my patients are men, if the wife, the daughter, the sister, the mother, the grandmother, or some sensible female in the family is identified, you need to go to the doctor, you probably will go. And it's some patients looking at things like Epworth, you say, well, do you feel tired? Well, if they felt like that all their lives, then they don't register it as I'm feeling tired. That's just the way I am. It's a relative term, and that's why Epworth doesn't work. But I think there's our understanding of where does bad snoring stop and upper airway resistance start, and then does that migrate into sleep apnea, where you desaturate. We tend to see younger males with upper airway resistance. So some of them come from the city because obviously they've got busy jobs, they have to function at work. Put them on CPAP, they do really well. Yes, multi-level problem. It's not just anatomy, it's not just a physiology, there's also neuromuscular elements there, and there's probably stuff we don't even know. Because actually, in the early 90s, there was a paper by a chap called Wright that trashed CPAP as a therapy and sleep apnea as a condition that you needed to treat. So the commissioners took it as an excuse not to fund it. So we're a good 10, 12 years behind States, Canada, Australia. And what you'll find is now we're starting to catch up a little bit. This is still in its infancy. There's still many things we don't know, and there's not one size fits all. So it's I think if you've got problems and they're complex, maybe if you get a lot of clever people together in a room, maybe you'll have a better outcome. So MDT working is something that we did push forward in the OSA working group. So actually from this April, it is a funded service to have more than one clinician from a different specialty in an MDT group in a sleep service. So that may be an opportunity for you guys to bond with your local team. If it's funded and somebody's paying for it, well, I don't see why you shouldn't get involved. Airflow dynamics. I think this is where, when I was a trainee surgeon, we used to use rhinometry and all that rubbish, doesn't work. This is more exciting. Airflow dynamics is where it's all going, and it's actually understanding airflow dynamics as the main principle for airway obstruction, and looking at laminar flow, turbulent flow, and the things that actually affect these things is very important for you. And actually, this is such a beautiful illustration because air arcs through the nose. That's the way it's supposed to flow. So anything that disturbs that will have adverse effects. And it's because, even the surgery, because this is the level of your inferior turbinates. People used to do a lot of turbinate surgery to shrink that down, but actually the airflow is not through the turbinates, it's not through the inferior turbinate, it's around the level of the middle turbinate. So one of my colleagues in America has some really good results by not doing traditional UPPs, but actually he's doing functional endoscopic sinus surgery, and he's not just looking at reduction of AHI by 50%, he's actually looking at AHI going down to below 5, and he's having very good results with that, but I only saw him in April, so it's still early days, and he needs to expand his studies. Manopathy, obviously you're all familiar with that. Looking at the oral cavity, something you guys do every day. It gives you the heads up, so if you see a Manopathy 4 in one of your patients, do the stop back. Just ask the question. I surveyed all the clinics in England and Wales in 2012, and actually it's quite interesting. About 33% are ENT and other. Respiratory only about 57%, but actually what doesn't reflect those actually respiratory a big overall slice. About 98% of all clinics have a respiratory physician in. So sometimes it's with ENT, sometimes it's by themselves. And there's max fax and anesthetics. I know Leicester was originated by an anaesthetist. So there's no fixed way it must be. I mean, all of them work reasonably well together. As long as you get good outcomes, I don't think anybody cares. We did ask them, well, how many of you examined the upper airway? And about 77% felt they did. Half of them looked in the nose. They felt it was a good thing to do. Most people looked, about 80%, in the oral cavity, which seems sensible. But only 20% actually nasendoscoped patients. And I'm an ENT surgeon, and I can tell you, I can't look into somebody's nasal cavity from the front and see through to their postnasal space. It's not possible, okay? And some of the other slides I'll show you, which will be interesting. You have these interesting bun fights with your colleagues. It's like, in 25 years, I don't see why I should look in the airway. I think that's madness. I think that's a bad idea. It's a bad idea to write it down. Not missing anything. Maybe you're at the stage in your career where you just don't want to learn anything else because you must have missed something. I'm not that confident about my practice. Then we had excuses about, oh, that's very costly. Oh, you don't want to be doing that. Or we'll do it if CPAP fails. Well, actually, if CPAP fails, you've got the trial of a unit, you've got a wasted mask, you've got another split night admission. You're looking at £1,500. Oh, it's painful? No, it's not. Not if it's done properly. You do it with KY jelly, no local anaesthetic, it's absolutely fine. But you visualize the airway. If you were a plumber, you'd look down the drains before you did anything to it. I'm saying if you don't look, you can't see. It costs £10 a patient. Allergic rhinitis, hugely engorged turbinates, that's a problem for you, and that's going to affect your airflow dynamics. This is evidence to show that allergic rhinitis patients do have trouble sleeping, and they feel unrefreshed in the morning. You treat them with topical nasal steroids and antihistamines, they tend to get better. If you put people on CPAP and you blow about 2 million litres of air up their nose at night, yes, the nose doesn't like it. Especially when you initiate. The first few weeks, what you find is that real stuffiness. You have to warn that your nose will feel like you've got a cold, but actually you don't have your cold. It's a reaction from the CPAP itself. So you give them topical nasal steroids, antihistamines, decongestants if you can, and they're not hypertensive. And then bent bent septum. That's going to deflect airflow significantly for you. Large nasal polyps, obviously you won't see that by anterior rhinoscopy. This is right at the back of the nose, but there's a certain sound to people who have nasal blockage from polyps. Other tumours, lesions, things like that, infections. You're not going to see this with anterior rhinoscopy. Large adenized pads. Every now and again you get a postnasal space tumour, which is not good news, and you wouldn't see that unless you examine properly. Nasal surgery. If you just do nasal surgery alone, you've missed the point. It's a multi-level airway disorder, so you want to actually try and cover your bases. If you're going to do surgery, do it properly. Nasal surgery is CPAP. I think that's actually quite a good thing. It can profoundly change somebody's response to CPAP therapy. So use it as a facilitator rather than, oh, surgery cures all. It doesn't. It may help considerably if somebody has high nasal resistance due to engorged polyps, a bent septum, or allergic rhinitis. So use it as a facilitator. This is one I took this picture specifically for you guys. It's like when the uvula looks like a foreskin, they've got sleep apnea. Okay? When you see the lines, because that's from last night, they've been battering the airway, this is what you want to see. If you see that in the mouth, send them for a sleep study. Well, that's pretty obvious. Big tonsils. There's no way that when this lady goes to sleep, she doesn't snore. It's like having 2 walnuts in the back of your throat. You take the tonsils out, so it's very easy. This one is more subtle. This is actually the tongue base. This is the vallecular. This is a vallecular tumor. So these are not common, but if you don't look, you won't see. This is an apneograph sleep study. They took a patient who's really good at complying with CPAP therapy. He's a lorry driver. He needs his license, so he complies very well with therapy. we operated on him, did a tonsillectomy, palatoplasty, reduced his turbinates, and reduced his AHI down to 15 from 65, which is good, but he still needed CPAP therapy, but his pressures have now dropped. This is the pre-op. You see all his pressures are riding pretty high. Then he had 2 weeks off CPAP because he couldn't tolerate it immediately after surgery. And then you can see all his pressures drop down. He was averaging about 18 before, down to about 10 now. Very happy, because the lower the pressure, the more easy it is to use it and less mass leakage you get. Car accidents. This is one that I wasn't going to talk about, but this is a very topical subject, and it's very important about you understanding the importance. Each fatal car accident costs 1.64 million. Okay, so in my county, we had the most obese population in Europe, poor roads. In fact, I was called once by the anaesthetist for a lady about to deliver a BMI of 60. Okay. How did she get even pregnant with a BMI of 60? You know, obviously it happens in Lincolnshire. It's going to be a turkey baster job, you know. It is, you know, you work with fat in a fat area, you see this more often. So, you know, it's one of those things. It's unfortunate, but I suppose it's good for me in the sense that I had a ready population. I had no service there, so we did some media, and this is I track all my patients electronically. So this is our growth. We're just about 2,000 patients now. After 7 years going at it, we thought we'd get about 1% of the Lincolnshire population, but it's proved harder than we thought. People don't necessarily batter down your doors, but it's been slow and steady. What we have seen, however, is road fatalities have dropped down from 79, which is roughly when I started my service in 2006-07, down to 39 as of last December. That saves 40 lives a year, 65 million a year, and the service costs about 2.3, 2.4 million a year. So it's a good return on investment of about 30 odd to 1. So when you're looking at commissioning and funding, and obviously you have to fund whatever you do, you have to have an economic argument for why you're doing this. Every pound you spend on this service does yield you money. These are not my figures, this is Road Safety Partnership. So these are the police force figures for calculation of road fatalities and how much it actually costs. A lot of figures quote at 1.25 billion, but in Lincolnshire we have a nice tight population. We know our numbers because the police work out the cost for them to cover the accident, the ambulance cost, the loss to society, the council has to repair the roads, and da-da-da. It goes on and on and on. So it's a huge impact area. They have stats, actually. If you go to Lincolnshire Road Safety Partnership, you can look at their tracking, so you can verify all my figures. These are the key things that look Corporate Manslaughter Act 2009. This is hugely important for companies and organizations and also clinicians. If you fail to keep data, if you make a wrong diagnosis. Well, we've seen what's happening with mid-staffs at the moment. It's not very pleasant, is it? So this is the kind of legislation the Health and Safety Executive is delivering on mid-staffs right now. So safe practice, stay safe, work with a good clinician and a local service that will support you in what you do. You need data. So we track everything electronically, got an online server that will manage all that for you. So the commissioners really like all this stuff because actually what you're doing now is you're showing that they're actually using the device, and then there's an improvement in quality of life over time, okay? So you can see that it started off with an Epworth score 22, tracked down to 6, and then very good usage at 92%. Because people, not unreasonably, if they're paying for a service, want to see bang for your buck. You have electronic patient records. And then people talk about compliance. Actually, if you look at overall crew compliance for myself, it's about 58%. If you look at actually excluding non-responder versus non-compliant, it goes up to 70%. I've looked at I've put about 800 people on personally myself, since 2005, 2006, and tracked my own data. I've lost about 100, so about 15% or so will fall off over time. But the ones that stay with you, they love it. They absolutely love it. They will do 95, 96%. They never not use the therapy. So what you find over time is the good users stay with you, and other people migrate away because they want surgery or other therapies. Surgery, highly contentious issue. ENT surgeons got panned roundly for operating inappropriately or just doing the same operations on everybody. You don't want to be doing MADs for everybody for the same reasons. You'll get panned as well with time. Surgery has a good role in selected patients. In my practice, as I said earlier on, about 80% go to CPAP. Don't argue about it. It's good therapy. It works well. And there's some people, like the 35-year-old man comes in with the younger girlfriend. There's no way he's taking that CPAP machine home. Otherwise, his relationship's over. You've got to understand that this is not going to work for him. So you've got to think, well, what can I do for him? Mandibular advancement devices work well. It's an option for that group. Some men in particular, they want to fix. You know, I want it done, doc. I don't care. Chop my head off. I want to be better. Failed CPAP therapy. Yeah, that's fair enough. Or more importantly, facilitating CPAP, particularly if they've got very high resting pressures above 15 centimeters of water. So success is, you know, it's all about, if you've got different modalities, it's your skill about tailoring which therapy is probably the best for this particular patient. So we have to follow our figures for 3 years because that's our funding arrangement with the local CCG. And I think that's good because most people only follow for 2. Pharyngeal manometry is another thing you can do. I use this as an excuse not to operate. It will tell you basically whether it's predominantly upper airway or lower airway. And if it's lower airway, you're getting CPAP therapy. So about half the people that have an apnea, I was thinking about surgery and I said, nah, I'm not doing that. You'll always be criticized for operating inappropriately. Because this is the apnea sleep study. And mandibular advancement devices, yes. I think you guys have a huge role to play here in about 10% of cases, and certainly giving us an opinion from your patient group, because one of the biggest problems we have is actually awareness. People don't know they've got a problem, and you may be the first practitioner they actually see. You can say, oh, by the way, are you tired? Are you snoring? You have a look, you know, because you have to look in their mouths anyway. You know what their body habitus is like when they come into your practice. It's something that you can look at and say, well, yes, I think you might have more than just, you know, a dental issue here. You might have a broader medical problem. And then if you're affiliated with a good unit, I certainly think that mandibular advancement devices have a role that was, first of all, it's very important to realize that actually NICE did recommend MADs in the NICE 2008 appraisal. And the thing about a technical appraisal from NICE is actually it's legally binding on the commissioners that they must pay for it. Because if you want to set up a service, you have to have some documents from NICE. A TA assessment is as high as it gets. You don't get any better. Below that you get a TA recommendation, which is helpful, but they don't have to pay for it. So as long as you have a good relationship with your local centre, you should be part of the team, because you can help a lot of people. And also somebody asked about dual therapies. Yes, it does work. There's some times when you're going somewhere for the weekend, a MAD works pretty well, but CPAP's better, or using the 2 in combination. Depends on each individual patient. So, good stuff. I audited, I use a local dentist, Dr. Nikki Burrell. She's very nice. She's in West Beach. I decided to use one person with one interest in doing this, so I get consistent results. I think she uses Sleepwell Appliance. And we tracked all our data that we sent to her during this time. Kind of failure to tolerate CPAP is one thing, because, well, you're going to fail in about 30% of CPAP patients. So what are you going to do with those 1,300? You have to find something else for them. You can't just say, sod off, you know, that's your ticket. So we collect all the data. Pretty big samples for us, actually, because, you know, 139 is... It's a good number. If you see people publishing on 27 and 28, I think you're looking at this. And all of our patients have a pre-MAD sleep study, and they will all have a post-MAD sleep study. This part of the study is really about the patient experience and what they felt was good for them. So I'll just break down by consultant. Somehow somebody was, well, 6% no consultant. That's just obviously a mistake. 73% had an improvement. Most of them felt it was comfortable, 74%. Most of them did not have side effects. Of those side effects, hypersalivation was the commonest, getting used to it. But 9% need the appliance changing. If you have dental work, then you need to modify it. 1% had difficulty using the appliance, but you do get some people who don't want this, don't want that. Nothing is good enough for them, nothing will work. So, you know, we've got Epworth's before and after. Overall, 70% were happy. That's a good, you know, you're looking at comparable numbers to CPAP therapy. So if I have 100 patients coming through and 80 go to CPAP therapy, 70% success there, then 70% success with the 10 that go through to MADs, and about 70–80% success in surgery. Those are still respectable numbers. And I think that this is where we should be aiming at, is not one size fits all, trying to tailor your therapy to the given patient and scenario and the funding issues that you have. But I think that OSA is probably the most exciting area in medicine to be in at the moment. It actually profoundly change somebody's life. It's so rewarding to do that. You can't not look at the nose, back of the nose or the upper airway. And if you fail to examine them, that's not good medical practice. In the States, certainly the anaesthetists are a bit twitched. They're paying out about $2 million for failed procedures. Can't intubate, can't ventilate, not good. Failure to assess the patient before trying to give them an anesthetic, not good. Giving somebody with undiagnosed sleep apnea morphine salts post-operatively, not good. I think ENT is part of an MDT, not just only ENT, it's part of an MDT. I think you should encourage every specialism to get involved, and you never know, we might learn something if we talk to each other. Thanks very much.